Hello, everyone. Thank you again for joining our webinar, Redefining Phenotype for Clinical Advancements in Variant Prioritization. I'm Dekel Gelbman. I'm the CEO of FDNA, and I'm very proud and excited to be joined today by two distinguished members of the genetic community. Professor John Carey, who is the head of the Division of Medical Genetics and Pediatrics in the University of Utah, and former editor-in-chief of American Journal of Medical Genetics, and Dr. Christine Stanley, the head of the clinical laboratory in WuXi NextCODE and the medical director of the Q&A Diagnostics. We will be discussing today the important role of next-generation phenotyping and how it plays a role in the next-generation sequencing era. All right, Professor Carey, I think we're ready to hear your presentation. Please take it away from here.
I want to thank Dekel and his team for this opportunity to provide some reflections on modern phenotype analysis, i.e. next-generation phenotyping, sometimes called nowadays deep phenotyping. For the listeners, I'd like to say that I'm a medical geneticist practicing genetics medicine and primarily dysmorphology in the context of an academic Department of Pediatrics. I'm not a laboratorian, but having said that, I've had the privilege of collaborating over 4 decades with many molecular geneticists, both here and abroad, and most recently with my colleagues at the ARUP laboratory in Utah, where I've attended regularly their, quotes, exome rounds now for 3 years. I mention all of this in introduction because in recent years, I've heard many of my clinical colleagues lamenting about a concern for a decline of phenotype analysis given all of our present options in next generation sequencing and so on. This concern was actually identified in an article that you can see on the screen now by Raul Hennicum and Les Biesecker in 2012, when they mentioned that, in fact, they thought that the new era of genome sequencing was going to actually bring in a new era of phenotyping. To quote them, "We predict that NGS performed for diagnostic purposes will yield variants in several genes, and consequences of these variants will need to be analyzed and integrated with clinical findings to make a diagnosis." And in fact, I think that Raul and Les are correct, and I hope to demonstrate that actually we have entered a new epoch of phenotyping. So after the presentation, I hope that you attendees will be able to recognize the importance of comprehensive phenotype in the NGS era, apply the current phenomic resources to phenotype analysis, and state the main principles in assessing the face, which I will use as an illustration of deep phenotyping. So here's a concise outline. After this background, I'm going to discuss some principles of phenotype analysis, review methods, many of which you'll be familiar with, talk about some resources, most of just the last few years, and spend the second half of the talk talking about phenotype analysis using the exam of the face and the objective documentation of the face as our example. In between, I'll actually discuss some patients and lessons I've learned for this new context. So on the slide now is the citation and title of a paper that I authored, published in the American Journal of Medical Genetics, Part C, last September 2017. And much of what I'm going to speak about in the next 5 minutes or so is encompassed in that paper in case you would like to read more, especially about some of the principles. On this slide are some of the standard definitions of phenotype. There are others. You can see the American Heritage Dictionary's latest definition, observable constitution of an organism. And then in the bottom, you can see the phenotype definition that Raoul Hennicum, Les Biesecker, myself, and others on the elements of morphology came up with a few years ago, all of the morphologic and functional attributes of an individual, except for the primary morphology of the genome. But look at the definition in the middle that I just took a quote from Gene Reviews, which is, I think, usually what we experience in clinical circles. That is, we say, well, does that gene, when mutated, have a phenotype? Or if you knock out this gene in the mouse, does that have a phenotype? And of course, the mouse has a phenotype, the person has a phenotype, but here we're actually referring to the disease condition being the phenotype. So note that there are different ways that the term actually will be used. You may know that the term phenotype was first suggested by Wilhelm Johansen, a botanist, in 1903, and he is the same person that coined the term gene and also genotype. This slide is a summary that comes from the paper I alluded to in 2017, listing what I consider to be sort of the domains of phenotype in the medical genetics arena. It might be different some other arenas, but I think it could be generalized. First, the definition of the phenotype, more specifically, if they exist, diagnostic criteria. Secondly, the long list that we see in all conditions of the spectrum of manifestations, components of the condition and complications. And lastly, the natural history of the condition, which is really the unrolling of the phenotype over time, the age penetrance. And again, that paper in 2017 discusses all these with more examples in much more detail. On this slide, I've just given a selected list of methods of phenotype analysis, again, primarily focusing on medical genetics and syndromes. For other disciplines, you would likely have a different list, which I'll mention in the next slide. Of course, there's our trusty detailed history and physical exam. In genetics, of course, we would use growth curves, ideally syndrome specific, anthropometrics, show you an example of that. Of course, images, which we're going to talk about more in a few moments, including of photography, but also of radiographic images, examples being like a volumetric MRI, which is often used in research studies, occasionally clinical, and even in the face, there's 3D imaging. In the psychiatric and behavioral realm, there are the standardized validated measures, which most of our listeners are familiar with. These are simply just examples of methods. PhenX has done a fabulous job actually compiling tools for all different areas, and I turn your attention to this database and this resource, relatively modern resource, where you could look at psychiatric tools, or you could look at cardiologic tools, or those involved in neoplasm, just again underscoring the advances that we've actually had in phenotype analysis just really in the last decade. But speaking of growth curves, most of us are familiar with the fact that growth curves are present for typical individuals, including children, but also are often syndrome specific. And here from a paper by Salmon et al., you can see the growth curves of the individuals with Costello in the lower part of the colored, and the typical kids in the dotted lines above. Just as an example, this turned out to be the cover figure for a special issue of the American Journal of Medical Genetics on growth curves. And I hope everyone listening is familiar with this particular work on Handbook of Physical Measurements. This is the next to the last edition. Newer edition has come out, and this is something we use in clinic on a regular basis for measuring, including measuring, in this case, the ocular region, the intercanthal distance, or the palpebral fissures, or outer canthal, when we're considering something like wide-spaced eyes or ocular hypertelorism, and distinguishing it from something like short palpebral fissures. Again, just giving examples of the growth curves in anthropometrics. In the area of facial diagnosis and research, I alluded to the 3D imaging. And here is a picture from one of the latest papers by Peter Hammond, now in Oxford, England, who's championed this 3D method here for one of the many syndromes that he has studied over the years. And I turn your attention to his many works over the last 12 years or so. In addition, there's an NIH-funded study of 3D imaging on the face, which I won't discuss in detail, but just mention it to you for your knowledge. But nowadays, especially in the last 5 years, there has been a proliferation of resources, which I think speaks to this notion of deep phenotyping. There's been a blossoming of patient registries. NIH has funded some of those. Patient-reported outcomes have become a very fashionable approach, and we're learning how to standardize those. Adopt the gene is something from the group in Nijmegen, where they actually help one who's adopted a gene to develop some registry data to study a gene, which has become a gene's effect, which has become highly important in our gene-first era. You can see some of the other resources, such as the Pheno database from Johns Hopkins. I already mentioned the Phenomics Toolkit, Phenotyps, which is a clinic-based resource for entering phenotypic data. And I suspect everyone is familiar with the HBO terms and their adaptation in Phenomizer. This is really meant to just be that list to underscore the point of the blossoming of these resources in just the last few years. Dr. Robinson's original paper on the human phenotype ontology is depicted here just to remind you of that paper. Others have appeared, and the HPO terms, I think, now are more widely used. So here's where we are. Phenotype analysis, the face. I'm going to spend the remainder of my time, I think about 8 minutes, on discussing some of the methodologies and using clinical examples related to the face. In 2005, an international working group that attempted to define standard terminology for phenotypic variations of the face, hands, and feet was created, was eventually called the Elements of Morphology, and this working group led to 6 papers, all now still free access on the webpage of the American Journal of Medical Genetics, published in print in January of 2009. Elements of Morphology then became a dictionary for what turned out to be most of the physical variations of the face. This is the cover of that January 2009, showing 6 examples. And on the left-hand part of the slide, you can see the 6 areas in which the working group devoted their time in actually cataloging the 401 definitions. Les Biesecker, one of the leaders of the Elements of Morphology, previously mentioned already, put all the images on an NIH free access web page that's cited here on the bottom of the slide, but FDNA very nicely compiled them all in a small handbook, which is very useful in clinic, and I actually distribute it to most of my colleagues when I can. That is still available through FDNA. So let's talk a little bit more about their resource called Face2Gene, which I will admit that I use on a regular basis in my own clinic. And Face2Gene is what I like to think of as kind of a mathematical representation of what we see as the gestalt of a face. It's built for a clinic setting using an iPad or a smartphone to take a photo image, as you can see in this slide. The face is detected in the image, and 130 facial landmarks are identified. These landmarks create facial crops around specific facial areas, and then a deep learning algorithm analyzes the areas and actually represents the image with a vector of numbers. It's actually a mathematical equation. This equation then distinguishes among syndromes. For myself, what I've learned is that some of the representations that occur in syndromes don't always match the facial gestalts that are at least in my head for a particular syndrome. In this case, of the Nicolaides-Baraitser syndrome. And you may be familiar with this seminal paper by Carey and her colleagues, where she showed that using FACE2 gene and coming up with a list of ideas based on this mathematical representation would have helped her more when she was in the position of deciding on an exome sequence, which turned out to document mutation of the genes in that chromatin remodeling pathway in her patients. I've had two recent patients where this has come up. One of them was a 5-year-old boy who was not able to speak and had very normal growth, had a lot of hair, especially on his arms and back, but I didn't think his facial features fit Coffin Cyrus, nor that I think that he had hypoplastic nails. He did have a mutation of ARID1B, which is the most common gene found in patients called CSS, but of note, when I put him in FACE2 gene, without even any clinical data, Coffin Cyrus came up first, and it was medium to high in its prediction. A few weeks ago, I saw a patient who had a developmental delay in short stature, who when exomes were performed because they thought she might have had a DeLonga syndrome of some sort, it wasn't clear. Turned out that she had a VUS of ANKRD11, the gene that underlies KBG. And as you can see where I'm going, when I did do the FACE2 gene analysis, she in fact, KBG came up moderate to high. There are other resources besides FACE2 gene in the research setting. Paul Kruska's group at the NIH with Max Munka now published 3 studies, one on Williams syndrome about to come out, where they use this digital facial technology. But in this context, let me tell you about one of my other recent patients, which I think also works toward where I'm going, and that is that when we're at gene first, as opposed to phenotype or phenotype first, we really have a different way of having to look at phenotype, cataloging, defining it. This is a place that the facial digital technology can come in. My patient was small for gestational age, still has short stature, global developmental delay in a mild category, number of minor variants on MRI, gray matter heterotopias, and exome sequencing show that de novo truncating mutation of the gene called SON or SON, which underlies a syndrome that's been called ZTTK because of the initials of some of the first authors. This is when he is about 2.5, not 5. If you look at the published papers on SON, which appeared just in the last 2 years, here you'll see in the next 2 slides all the pictured patients in the literature except one. It's hard to say that there's actually a face, but you notice the individuals are all at different ages, probably even vary in ethnic groups, but I don't think I could say from these pictures that there is a face. And here's an MRI of the literature patient that was quite similar to my patient, allow us to draw the causal inference that he had SON as the basis of his growth failure, intellectual disability, and congenital malformations. That was the second paper, and here are some of the pictures from that particular paper. Again, I'm not sure there's a face yet, but I think we're gonna find that out because FACE2 gene and FDNA has already created an image representation of the syndrome, and they just took this off and provided it for me for the talk today. So it really is truly hot off the press. Just as I close out my talk, just to mention there are some recent excellent papers in the literature that talk about this use of phenotype in the context of variants. We're going to hear much more from Christine about the variants and interpretation. This paper by Anna Del Luria and David Miller is quite excellent. I refer that to you as a resource for a lot of this discussion. It's especially in this area of gene first as opposed to phenotype first. And this second paper in Genetics and Medicine, published not so long ago, is also an excellent read. So I thank you for your good attention. I close with just mentioning the ACMG guidelines on causal inference from variants, because of course phenotype is well in use of phenotype is well embedded in those guidelines. But I can close by saying that this new era of genomic medicine and NGS, in my mind, like Hennecum and Biesecker, has ushered in fact, a new era of phenotyping. Thank you for your attention.
Thank you so much, John. I think this talk really exemplifies the role that next-generation phenotyping and phenotyping is taking in the clinic and why it's so important. I would, before I go back to Dr. Christine Stanley to talk about the lab's perspective and why phenotyping and specifically next-generation phenotyping is so important for the analysis of next-gen sequencing, I'd like to remind the audience once more that you can and you're encouraged to submit questions both to John and to Christine. So Christine, with that, please enlighten us on why next-gen phenotyping is so important for variant prioritization.
Thank you very much. I want to thank the FDNA for hosting this webinar today, inviting me to discuss the importance of clinical phenotypic information in the era of clinical next-generation sequencing. And I also want to thank Dr. Carey for the excellent in-depth review of phenotype collection and the tools that the experts like him are using in this era of medicine to define the patient phenotype in such a precise way. I'm going to discuss what happens once the clinical phenotype has been defined in the clinical diagnostic laboratory setting. Start with my overview. At the end of the webinar, hopefully you will understand the importance of comprehensive phenotype in clinical molecular genetic diagnostics, understand how the phenotype is used for variant classification, and appreciate the role of digital tools in personalized genetic testing to advance clinical genomic medicine. I'll be reviewing the role of the phenotype in variant prioritization in 3 parts. First, I'll review the variant's phenotype in clinical workflow and move into reporting, and then finally the use of digital tools to enable diagnoses. So let's begin with clinical workflow. Before we get too deep into reporting, I just wanted to do a basic overview of the genetic sequencing laboratory. You're going to obtain your biologic sample from the patient, usually blood or saliva, then extract the DNA from that sample and generate digital sequence information. So here's where you have gone from biological patient sample to raw DNA sequence data, living sample to data. Then you are able to take that data, align, annotate, and filter. So you have to tweak it a little bit so that you can read it, interpret it, and report it. And before going any further, I just want to take a moment to define a variant, because I'll be using that term a lot. A variant is simply a departure from the reference sequence, so that if the reference has a G at a location in the genome and the patient has a T, then that T is a variant. For example, consider the 2 sentences, I have a dog. Let's say that's the reference population. Everyone in the population has a dog. But the patient has a change. The G is now a T. So changing this to I have a dot. So this patient has a dot instead of a dog. In this example, the G to T is the variant. Although both may be cute in their own way, most of us would consider this minor change in the sentence to have a dramatically different result, changing dog in the reference population to dot in the patient. Without entering into the debate, your tolerance for this change may depend on whether you are a dog person or a dot person. The point being that something very small in the right context can cause a big change. So to relate this back to reality, when a patient submits a blood, saliva, or other sample for genetic sequence analysis, the lab isolates the DNA and reads the letters, which are A, G, C, and T, which make up the patient's DNA sequence, and compares it to the reference sequence to identify any changes or variants. When one reads the DNA sequence for all the genes in a patient, this is called whole exome sequencing, where the exome is the approximately 20,000 genes in our genome. Therefore, if a variant in the patient's DNA changes a gene, it may affect the expected product of the gene and result in clinical disease. So what do we actually see in the lab? Here we look at a sequence read alignment, which shows good coverage and maternal inheritance of an X-linked variant in the CULB4B gene. If we were to zoom in, we would see the A's, G's, C's, and T's that make up the DNA sequence. Gray horizontal bars show where the patient sequence is identical to the reference. Next generation sequencing sequences the same region many times over and aligns the repetitive sequences to a normal reference sequence. The green here is a variant that is on the X chromosome. Since the mother has two X's, you see she has a mixture of the normal sequence and the variant. The male child sequence is on top in the top panel, inherited from mom, and the father sample is in the bottom panel. Father's DNA sequence matches the reference sequence. No longer deemed investigational by all, hooray. Some payers are beginning to publish favorable coverage policies for whole exome sequencing, but it is clear that phenotype must be provided in order to justify the testing. So here we see Cigna states that whole exome sequencing requires phenotypically affected individuals. United Healthcare states clinical presentation suggests a genetic cause, and Blue Cross and Blue Shield says a genetic etiology is considered the most likely explanation for the phenotype, to name a few. Insurance companies don't have much of an appetite for uncertain results, and whole exome sequencing creates a large data set of variants, many of those which are uncertain because of how many genes are being sequenced. So they only want to pay for patients who are most likely to benefit from the testing. Also, in order to focus on a subset of those variants, the ACMG, American College of Medical Genetics and Genomics, advises that the phenotype helps with enabling the lab to appropriately filter and prioritize variants, identify a possible constellation of symptoms and findings in the patient and for future clinical evaluation, and also increase knowledge base for variant information. So the phenotype is extremely useful for justification of insurance payment as well as for clinical interpretation. One of the first steps in diagnostic testing via whole exome sequencing is collection of the phenotype. As I said, the justification, as I just mentioned, for the testing itself is dependent on a complete and accurate clinical intake. Unfortunately, labs don't receive comprehensive or deep phenotype information as we would like. In the past, clinical information was not required for testing, so there's a history for clinicians not necessarily submitting clinical information. When we order single gene testing, for example, lab requisition forms only require the clinician, or in the past have only required the clinician to check a box indicating carrier or diagnostic testing. Patient was presumed to have the disease that was indicated. This was an issue even back then, about 5 years ago, when we were doing the single gene testing or small panel testing, because many clinicians would also order the testing as a rule out for disease. The problem really became magnified when gene tests went from a few genes to hundreds of genes. For some other reasons, labs receive incomplete or inaccurate clinical information today, maybe because the person is too young to present with clinical symptoms. You see this often in neonatal testing. There's scant, incomplete clinical history. The specialist is focused on a narrow clinical symptom or chief complaint. More than one disorder may be confusing the phenotype. Clinical symptoms have softened over time or have been corrected. Disease is multi-system or mild. There are mild systems for broad phenotypic spectrums of diseases. That's just some of the possible reasons why we might get an incomplete phenotype. As an example of incomplete phenotypic data collection, this is a DNA diagnostic report issued by Cortigen Diagnostics. Even though we had an incomplete clinical phenotype, we were able to reach a positive result because of the nature of the genetic variant identified. Loss of function variants are suspicious type of variant because many of this type are associated with disease. However, some variants like missense variants, which is a variant that results in a replacement of one amino acid for another, are often benign, but they can also be pathogenic. So had this variant been a missense type, it might have been classified as a variant of unknown significance or uncertain significance, and the report would have been uncertain. This is an example of images of patients with pathogenic changes in the gene CUL4B. Information was not provided to the clinical laboratory regarding the likely facial, gestalt, and small extremities associated with pathogenic variants in CUL4B. Given the identification of a pathogenic X-linked variant in the previous example, the expectation is the patient had the characteristic clinical features associated with pathogenic changes in this gene. However, the molecular diagnostic testing lab is unsure whether these clinical features were absent, not prominent, or whether the information was just not provided. Therefore, in that previous example I showed you, had the variant been a missense variant, but the clinician used an app-like-based gene to deliver phenotypic information on dysmorphic features, it is much more likely that even in the event that this were a missense variant that hadn't been reported before, that the patient's report would have indicated that this change may be associated with disease. At which point the clinician may decide to review other clinical symptoms in the patient to see if this disease is a good explanation of the patient's clinical presentation. As you can see, the phenotypic information combined with the gene sequence information is a powerful combination. So far, you've heard me use the term pathogenic quite a bit, so I'll take a moment to review where that terminology comes from. These are the terms adopted by the genetics community to describe the severity of the variant identified in a patient. Variants are divided into 5 categories: benign, likely benign, uncertain, likely pathogenic, and pathogenic, which really breaks down to 3 categories, since likely benign and benign are treated essentially the same from a patient management and actionability perspective as are likely pathogenic and pathogenic. So variants are either looking benign, meaning they have little or no impact on the gene product and then the patient, or pathogenic, meaning they have a negative impact on the gene product and possibly on the patient. So, and then if it's neither of those, you can't make up your mind, it's uncertain. To make the final classification of benign, pathogenic, or uncertain, the ACMG together with the AMP proposed 28 lines of evidence, which when incorporated into a proposed algorithm will generate that overall score classification. This evidence-based variant classification is meant to standardize a process and align labs to promote more accurate clinical reporting, because there was, and still is, really, inconsistency in laboratory reporting of variants. The ACMG AMP then followed up on that publication with a second publication comparing lab assessments of variants based on ACMG standards. Of the 28 lines of evidence recommended by ACMG, which are used to generate the variant classification, it seemed that a handful of them were used more often than the rest, with the line of evidence PP4 associated with the patient's phenotype being a lesser used line of evidence. It should be noted here that not all lines of evidence are created equal. There are some more heavily weighted lines of evidence that contribute more profoundly to the overall score or classification of the variant. For example, a variant frequency of greater than 5% in a healthy population without any other conflicting evidence is the only evidence necessary to classify a variant as benign. All other lines of evidence must have additional lines to support classification. When there is no evidence or the evidence is conflicting, the variant is deemed a variant of uncertain significance. When we look at the 11 most often used lines of evidence, with a few added in from personal lab experience, they appear to be mostly the ones that are easily accessible and likely automatable. Because several lines of evidence are opposites, for example, the in silico is BP4 for benign and in silico evidence for pathogenic is PP3, you can really distill these down into 6 categories. In silico tools used to protect the impact of the change, de novo, meaning the variant arose new in the child, population frequency, for example, very rare or very common, reputable source, meaning a laboratory with a credible reputation, the expected impact, for example, null variants predict loss of function, and functional studies reported on the specific variant. There are 7 lines of evidence if we receive and more reliably use clinical phenotypic information. That line of evidence, noted as PP4, incorporates the patient's phenotype into the classification of variants. It was not a commonly used line of evidence in that previous graph, but it could be with better, deeper phenotypic information. Tools that help incorporate phenotypic information into clinical reports can make this line of evidence more accessible for variant scoring to increase a more definitive variant classification and improve diagnostic yield of genetic tests. So I'm going to look at another case example. The clinical phenotype that was provided elevated this missense variant seen in Med12 from uncertain to candidate. In general, variants with partial clinical overlap can prompt deeper phenotype collection. In this case, inclusion of the symptoms on the result report to the clinician commonly associated with Med12 related disease can assist the clinician in collecting or reporting additional phenotypic information to provide back to the lab, creating a positive feedback loop, which I'll expand upon in a minute. Therefore, clinical phenotype is most important for both as a line of evidence in variant classification, which can be the difference between a positive or uncertain report, and for filtering the initial gene list, such that if you omit clinical symptoms, you may omit the causal variant from the report altogether. Genetic reports that include phenotype and disease associations can help sort and direct follow-up for deeper clinical phenotyping that may result in reclassification of the variant and change the outcomes of the report. I'm now going to move on to the personalized genomics and revisible reporting. But first, I just want to back up a little bit to just talk about how detailed phenotype is used in clinical diagnostic reporting, especially as it's related to whole exome sequencing and its use in automation. So once we have the patient's clinical symptoms, we convert those into a standardized phenotype language called HPO, which stands for Human Phenotype Ontology. It's a numerical representation of the clinical symptom. Whole exome or genome sequencing is performed by comparing the patient's clinical symptoms to the HPO terms associated with the patient's specific sequence variants. So the term whole exome is a little misleading because while we sequence the whole exome or all the patient's genes, we don't report out information on the whole exome. Bioinformatic filtering of the HPO terms occurs against the HPO terms associated with the genes where variants were identified in the patient. Therefore, we're looking at both the patient's symptoms and the variation identified, and we are determining that overlap. So what we really have is a personalized gene variant list. And what does that mean? It means that we are only looking at the variants possibly associated with the patient's clinical symptoms that we are aware of at that moment in time. And these personalized variant lists can and will change over time. Information on the phenotype changes, information on the genotype, the information that we know about the genetic variant changes. So these are really dynamic results, and we need to accommodate that. So what does this mean for diagnostic reporting? It means that we are poised for a major clinical advancement in diagnostic reporting based on new technologies enabling real-time report updating and revisions. Clinical genetic advancements allows for a dynamic report filtering approach rather than a static one, and enables precision medicine by rapid reissuing or issuing of iterative reports that can then enable connections to clinical trials and targeted therapeutics at a much faster pace. Current lab reports are static, moment-in-time reports. They're not flexible to updating with new information because they were not designed to allow for the dynamic nature of information such as patient clinical presentation, new information on genes, variants, and diseases. Therefore, currently, labs must have as complete a picture as possible on the onset of testing to receive the most accurate diagnostic report. The fewer HPO terms reported at onset of testing means fewer variants or that smaller net to pull in through that filter. So here we see that we filter variants based on several factors such as the type of genetic change and what its impact is with the HPO terms from the patient. After filtering, each patient will have dozens or more variants of uncertain significance identified. It's up to the geneticist to investigate each variant and its possible association to disease. As more information is gained in genes, that personalized gene panel should grow. Therefore, we need to have a dynamic process to capture those new connections. An ability to take in multiple lines, symptoms, or test results gives an advantage because all the information is in one place and is being viewed simultaneously with the genetic information. And then the other side of this is that it's important to remember that the genetic test results can also direct the type of specific phenotypic collection needed. So you might get a genetic result which makes a particular gene suspicious, and that the symptoms that are associated with that gene, you may be able to follow up with additional confirmatory tests. For whole exome, whole genome lab results, variants typically are filtered based on the patient's clinical phenotype. The more limited, as I said, the phenotype, the greater the risk the variant will be filtered out of the data set. Conversely, the more clinical information provided, the more likely to prevent that disease-causing variant from being filtered out of your data set. Candidate variant lists may point to several disorders, whereby additional phenotype collection may help reprioritize those variants. Pertinent negatives can be added for reprioritization. Clinicians can look for subtle signs and symptoms that they may not have appreciated before. Biochemical or other testing may be ordered, and results can redirect variant prioritizations. This dynamic feedback loop of clinical symptoms and genomic information can be achieved through FDNA's tool of Face2Gene, and also WuXi NextCODE's dynamic interface, which can facilitate the complete clinical and molecular diagnosis and characterization of variants. Here we see just Face2Gene's PEDIA study, how it highlights the improvement in diagnostic yield with increasing phenotypic information. And to further demonstrate how deep phenotype works, a 2016 study in the New England Journal of Medicine funded by BC Children's Hospitals Foundation was conducted using deep phenotyping and whole exome sequencing in 41 probands with intellectual disability and developmental delay and unexplained metabolic abnormalities. While typical diagnostic rates are all over the place, reported up to around 40% for whole exome sequencing alone, their study showed a diagnosis of 68% in patients with the identification of 11 candidate genes newly implicated in neurometabolic disease, and a change in treatment beyond genetic counseling in 44%. That certainly puts that up on the upper end of diagnostic yields for whole exome sequencing. Here's another real example of a clinical test result where 2 loss-of-function variants were identified in trans, 1 from each parent, in the SERP1 gene, which causes Leigh disease. It's extremely important that comprehensive clinical information be provided, especially in cases where the variants are not as suspicious as reported here, or in the absence of parental information. Understanding the phenotype associated with genetic disease can also allow the clinician appropriate referrals for multi-system disorders requiring a multidisciplinary team and provide potential prognostic information for long-term follow-up care for the patient. The inheritance of the disease will allow the parents to make informed reproductive decisions. Ultimately, a dynamic feedback loop between the clinician and the lab can provide not only diagnostic and prognostic information, but could also assist in variant classification, so the next patient with the same variant receives a more definitive answer. So as we embark in therapeutics and genetic diseases, we recognize the importance at arriving at a diagnosis early, since therapies tend to have the most significant impact when administered as early as possible. And this is actually a very exciting time to be in genetic medicine. I'm going to move down to talk to the digital tools enabling these diagnoses. So far we've discussed next-generation phenotyping and the use of computational techniques to integrate phenotypic data into the analysis of human genetics and health, including capturing, structuring, and interpreting complex clinical information. We've reviewed how this information improves variant classification and diagnosis, and arriving at diagnosis has many benefits, such as identifying needs for multidisciplinary patient care, assisting medical management, not only treatments, but also agents to avoid for patients with particular genetic variants. It helps justify payer coverage and reimbursement, facilitates N-of-1 clinical therapeutics, identifies patients eligible for clinical trials, allows building of clinical cohorts, enables lifelong medical management. It goes on and on. So we can see that this phenotyping is really critical for these diagnostics, and the diagnostics are really critical for patients' management. And phenotypic data isn't just about recognizing the disease-related features that we described previously. The data affects molecular interpretation, clinical trial design, patient outcomes, research and discovery. Really, every aspect of healthcare can be impacted by understanding the phenotype. So WuXi, NextCODE, and FACMG enable dynamic report interpretations. As phenotype changes due to new symptoms, age-related symptoms, new test results, new genetic information of disease associations, broadened clinical spectrum, new inheritance patterns, and correction of previous inaccurate information, that allows updated findings and updated decisions. You can also, patients can decide that they want to receive secondary findings maybe after the fact, so you can update that way. You really need this dynamic reporting tool to be able to do that. And all of this can be imported and used in an electronic fashion for up-to-date information. WuXi NextCODE's clinical sequence analyzer software tool enables the clinician to see the most up-to-date information at any time. And because the variants are not pre-filtered, these changes can enable rapid updates, which in turn shortens the time to diagnosis and treatments and empowers hospitals, clinicians, genetic counselors to see the most current updated variant lists and classifications. Just to briefly talk about the clinical sequence analyzer, it's WuXi NextCODE's tool used to review patient information and variant information together for clinical reporting. Incorporated into the clinical sequence analyzer is both the FDNA phenotype information and the ACMG variant scoring tool to allow variants that are most likely to be associated with the patient's clinical phenotype to rise to the top of the list and enable easy accessibility of the genetic information to empower and enable powerful outcomes. To learn more about this, I'm going to be giving a presentation at ACMG with FACMG and how that FACMG and WuXi NextCODE digital platforms are integrated for clinical diagnostics. So I'd like to thank you for giving me time to present, and I guess we're going to take questions now.
Well, Christine, thank you very much for sharing this information with us. And John, again, thank you both for amazing presentations and very educational. We do have time to share some questions from the audience. So I think the first question would be to you, Christine. Do you think that a detailed phenotype is more important when you do whole exome sequencing rather than gene panels?
It really depends on how big the panel is. Smaller panels that are confined to a really tight phenotype can be interpreted with less phenotypic information because the patient is assumed to have the phenotype associated with the panel. But when the panels get really large in the hundreds or even over 1,000 genes, they can actually produce more variants than whole exome sequencing, because the labs for panels typically report out all the variants associated with the genes in the panel. And for whole exome sequencing, the variants are those that are associated with the clinical phenotype. And because payers have been giving like poor reimbursement history with large panels, it seems like the way things are trending is either to start with single gene testing or very small panels, and then rather than go to the mid-size or bigger panels, just to reflect straight to whole exome sequencing if that doesn't work. And then whole exome sequencing does require a detailed phenotype. So it really makes sense to get that information no matter what kind of test you're ordering.
And I think a follow-up question from the audience, do you sequence all 20,000 genes when you do exome sequencing, whole exome sequencing, or only just genes with known functions?
So you sequence, if you're doing, there are different types of whole exome sequencing. So there's clinical exome sequencing where you're sequencing just the genes that are associated with the clinical disease. And then you can do the whole exome sequencing as well. And that would just be, the clinical exome sequencing is really more of a really large gene panel. And then whole exome sequencing is all the genes, but those genes that aren't currently associated with the disease won't have phenotypic information associated with it, so it won't pull through during that matching process. But it will be there in the event that there's a new disease association with a gene that is described later. Then you can reanalyze that information and potentially have a match there.
Thank you. Now, a question to John Carey. Do you and how do you think that the introduction of tools like Face2Gene into clinical practice will change the clinical approach in the future? And if you do, who do you think is going to benefit the most from it?
That's a great question. Thank you. You can hear me now, Dekel, okay?
Yes, John.
Good, thanks. It's a great question. Because in fact, I think it emphasizes the point that the tools, some of which I mentioned, like Phenomizer and of course Face2Gene and other digital technology, are really assistants. They probably will expand the list of ideas that we might have, perhaps at a new level compared to resources in the past like London Disc Morphology. But I think it'll still be up to us as clinicians to define those conditions, weigh different component manifestations, and make that judgment with the help of some of these additional tools as to who has the condition and who doesn't have the condition. So I would see that both we would benefit by having expanded knowledge and tools truly at our fingertips, but there's no question that the patients will benefit with the increased chance of making a diagnosis, or at least helping us in our genome analyses. I would like to add that there is a question lower down, which is related to this question, that I wanted to add, and that is someone asked about that VUS in the patient that turned out to be with Face2Gene high with KBG. I would say that we did not make the judgment that that patient had the KBG syndrome based on Face2Gene, even though it was medium to high for the face. We're now working on getting functional studies done because we now have a higher suspicion that that VUS may in fact be causative. So good question in the context of the first one you asked me as well.
Thank you. There's another question that I'm not sure is for FDNA or for John Carey. When will the new elements of morphology come out? So I'll take a first stab and say that the actual booklet will come out as soon as there's an update to the publications. But John, do you have any insight on when are we going to see updates to the series of elements of morphology?
Thank you for that question. There have been two updates that have occurred after 2009. One was the standardization of terminology of abnormalities of genitalia. The second which I cited earlier when I mentioned definition of phenotype. There was a second general definitions, including malformation, deformation, disruption. Both of those two additional ones are free access on the American Journal of Medical Genetics Wiley web page, added to the original 6 papers. But having said that, there are committees that have been discussed but not finalized on skin, on teeth, on chest and back, and on the rest of the limb other than hands and feet. And I'm embarrassed to say that we've been stalled for a few years in making those happen, but all of those that I just mentioned are in the planning stages. For phase 2 gene to have another booklet, Dekel, you could add the abnormalities of the genital tract and the broader definitions, which would thicken your handbook a little bit if you want to in the future.
Thank you. There's a question here for FDNA, but I think also to WuXi, and that's how can clinicians use phase 2 gene to send phenotypes to labs, and can they get the results back through phase 2 gene? And I think, you know, I'll take this question. Well, clinicians today can already share phenotypic information through phase 2 gene just by clicking a button that says share with lab. And we have many labs that are already part of this and have connected with phase 2 gene to support these clinicians and to integrate phenotypic information into their clinical analysis or genome analysis. And WuXi really is leading the curve here, working very closely with them to enable a very robust pipeline that allows clinicians to share phenotypic information seamlessly with WuXi, and for WuXi to integrate that phenotypic information, as was just explained, with their analysis. The next phase would be to share that information back with the clinicians so that we can keep them working in a single environment and be able to share as much data as possible to augment the analysis and the clinical evaluation of patients. Christine, if you have anything to add to that, please.
No, that was great. I can just underscore again that I'll be presenting that integration between phase 2 gene and WuXi at the ACMG conference in 2 weeks.
Terrific. And probably the last or close to last question, how important is incorporating text or clinical notes into this analysis? I know that at FDNA we're working to build technologies that allow us to take clinical notes from physicians and convert them into HPO. John, you referred to HPO as an ontology being used for phenotyping. And part of that is to be able to scan retrospectively electronic medical records for research purposes. Christine, how important is it to you to receive those clinical notes or phenotypic annotations from clinicians?
Yeah, it's really important, and that is where natural language processing is really important to have integrated, and it is on WuXi's roadmap to do so. And I'll probably, you know, have a better talks with some of my colleagues about where we're at as far as that roadmap. But certainly, anytime we can take vast piles of clinical notes and then extract out the pertinent information from it, that saves a lot of time on the clinical interpretation side of things. So that certainly is the direction that we're heading in this next generation of clinical phenotyping and sequencing and reporting.
Thank you. And we do have time for one more question. The question is, what happens to the photos after they're submitted to phase 2 gene? So I'll take this one. Phase 2 gene has developed a technology that allows us to basically de-identify all facial photos and turn them into a mathematical representation of a patient's phenotype. I think John's presentation had a slide that showed you a very detailed phased approach of that process and how the photo actually goes through that deep learning system and results in something that is not readable for a human eye. The photos themselves are stored securely in a HIPAA and GDPR compliant way for the user, which allows the user to actually view the photos, but no one else can view them. And what goes to FDNA and to the algorithm is basically just that mathematical representation. I want to thank you again all for attending, for Professor John Carey and for Dr. Christine Stanley for presenting their very educational talk today. And we had a lot of questions. Unfortunately, we couldn't present all of them, but we will include them and answers in the email following this webinar. And we're also going to make available a recording of this webinar in that email so you can share that with your colleagues. Thank you again for being in this webinar, and we wish to see you soon at the ACMG meeting.